Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast. My name is Terry Fletcher, and I'm happy to have you with me today. I hope everyone is getting out of the office and out of your house and enjoying some of that nice weather that's out there. Well, except for you guys, you folks in Colorado. Sorry, but I've been watching baseball and I saw your snowstorm just a couple of days ago, and I'm like, hey, it's April. What's going on out there? So hopefully it's melting at some point and it's not just the sea of white. But we're happy to have everybody here today. And we are going to talk about the topic called interoperability. So this is something actually I've been contemplating as this term has been coming up and really being talked about in healthcare associations and around the healthcare information technology sector. And it's interesting because when you look at the term itself, you're thinking, okay, what is interoperability? Why has it been thrown around the last couple of years? And really, as healthcare professionals, what do you need to know about it? How does it affect you and your physician? And does this have anything to do with advancements in medicine? I also have a couple of coding questions for you today. Actually, 4 I'm going to bring you today. So we do have a lot to cover, and this may go just a little bit longer than you're used to. I actually had the last 2 that only went about 20 minutes. So I think we're going to have a little bit of an extended time today, which I hope you're happy about. I actually had a couple of really sweet emails and social media direct messages saying, could you go a little bit longer? And I was like, sure, let me see what I can do. So I like to think that this is a good drive to work. So for those of you that have to drive to work, 20 to 30 minutes, hopefully we get a chance to chat and talk together in the morning or when you're driving home. So hopefully this is a good option for you. But first, the Codecast podcast is also brought to you by Allegheny Health Network, Western PA's healthcare quality leader, ahn.org. So to define interoperability in the healthcare system, so what it is it's the ability of different information systems, devices, or applications to connect in a coordinated manner. So within and across organizational boundaries, they're trying to access, exchange, and cooperatively use data among stakeholders with the goal of optimizing the health of individuals and populations. Okay, I know that sounds very technical, but basically what it means is interfacing. So this computer interfaces with that computer, that interfaces with this technology, that interfaces with that computer or device, and everybody gets access to everything they need. But here's the thing. So experts talk about interoperability in terms of great progress, new opportunities, and advancements in patient care. And the doctors basically, with the same topic, sometimes they're eye rolling and they've got some skepticism and even some fear of costs. Think about how much it costs for you to go from paper charts to your EMR. And poor interfaces and more government interference in their workday. So I can understand there's a little bit of fear when it comes on to thinking about interoperability. But the fundamental idea of the term interoperability is simple. Doctors should be able to access all data regarding their patients, irrespective of where in the healthcare system the data was generated or what software was used to generate it. But the path to getting there requires solving a complicated puzzle because of the linking of competing businesses, state and regional information exchanges, technology-focused nonprofits, and federal regulations. Think about just a really good example. If you have an iPhone, which I had to get a new one today, my 6 Plus finally just lost its mind. So now I have an 8 Plus, but my apps are not downloading. But let's say you have an iPhone and somebody else in your house has an Android. Well, you can't share applications. Also, you can't share things on an iPad if you have an Android. So interoperability has pretty much kind of the same concept. So if you look at it as an example in healthcare, so let's say I'm at a facility that uses Epic as their electronic health record, and I'm getting patients from another facility using the Epic EHR, then it's not so bad. But if they're on any other EHR, like eClinicalWorks or NextGen or Greenfield or anything like that, the data is still coming by fax or email, and it's difficult to get the information, not only from an interface perspective, but let's face it, the willingness of the hospital or the other entity wanting to share the information. So in one hospital, you may have to cut and paste information into a HIPAA compliant email and then actually send it to yourself at another hospital. Sometimes even if they're both on the same electronic health system, it doesn't always interface with each other. I do a lot of auditing, as I've mentioned, over the last year and a half doing the podcast. And there's two ways that it comes. Somebody can say, Terry, can you audit for us 100 charts? And I give them the option. I say, absolutely. You can send it through secure email, or your IT person and I can set up where I can have direct access because I have a HIPAA compliant computer, and I can access through password protection. And I have to go through 8 passwords. I mean, there's a lot of password protection when I access from a remote space. Or you can send them to me by paper, and that you're seeing me do an eye roll, I'm just saying. But it's amazing to me how all of a sudden FedEx records will show up in my mail slot, and I'm just like, oh my goodness. So I much rather do it through a remote access. But sometimes even when I see that information, I'll see on a SOAP note, it says one thing, and then on the final dictated note, it'll say something else. And they haven't interfaced with each other. And I'm not seeing that where the doctor ordered a lab or a test where it's interfaced with the actual encounter that day. And that can be a definite issue. So I've seen baby steps when it comes to progress towards interoperability, and in some ways it's gotten worse as more technology floods into healthcare, adding more data from devices that may not connect with electronic health records and other healthcare software. So even if we had complete interoperability and access to data, here's a question. What do we actually do with all of it? So ultimately, healthcare providers are limited in how much time they have. The ability to find information quickly is really just as important as access. So I was mentioning not too long ago that I really like to do my due diligence before I do a podcast. So I read everything from, Inc. magazine to Entrepreneur magazine to Medical Economics to the Journal of American Medical Association, you name it, I get my hands on it. And then I try to verify it through authoritative references and also through my own professional experience. I've been in the industry over 30 years and just really trying to figure out, what is accurate and what isn't. Well, I came across this article recently, and it was by Dr. Peter Bosch of Medical Economics, and he's the Senior Director for IT Quality and Safety Research at the National Health IT Policy at Columbia, and it's a base MedStar Health program. And he says part of the problem is what a doctor needs to effectively treat a patient is a constantly moving target. And I would have to agree with that. Before there were any digital ways to receive information, or what they call interoperable, or fax machines, doctors were satisfied with just getting the information they receive out of the mail or courier. I remember when I first started in healthcare, we couldn't wait for the mail to get there because we had to get our pathology reports and our lab reports and our x-ray results in the mail. So we didn't have fax machines back then. I can't believe I just said that out loud. The expectation of what is considered physician's work also changes. The expectations of whether we're getting what we need will change with it. So even in situations where information systems are connected, the data that doctors need will vary also by not only the physician's role, but their specialty and the patient encounter. So for example, what an emergency department doctor requires to see for a patient complaining of chest pain is different from what an internist needs to be doing in a general checkup. And physicians also need a broader pool of information, including non-clinical data, now such as insurance coverage and prior authorization requirements. We know those can be a pain. But the foundation of today's interoperability problems start with the Meaningful Use program. So it was created, the Meaningful Use Stage 1 created a situation where many vendors were fighting for market share in the blooming EHR field. And doctors often ended up with software that wasn't adaptable to changing needs in companies that weren't interested in sharing patient information with any competitors, even though it's what physicians needed. So when information was shared, it was often little use. I saw this so often when electronic medical records first came out. I have so many horror stories of moving from a page 1 or 2 of a discharge summary to a mandated 50 to 100 page summary that basically said nothing. It was just filler. And a lot of doctors found it was just a waste of time reading it or even reviewing it, and just easier just to ask the patient, why were you in the hospital and what are your symptoms? So EHR purchases made in the early days of meaningful use are still haunting the physicians today. What the rules were is the first requirement to receive your incentives in stage 1 of meaningful use was that you had to obtain health IT. Didn't matter what you bought, how you used it, you just had to say you bought it. Now you may be stuck with what you had and hope that eventually it evolved, or maybe you picked the right one to begin with. And remember how expensive that was? And you were even given a small incentivization, so incentivized just to find any kind of EMR. And they were in the early stages. I remember there was one company who I can't really say out loud, but they jumped on it right away. They had terrible support. They were basically offshoring all of their support, and you couldn't understand anybody on the phone. It was terrible. So not only could we not get access to people who understood their own system, but the training wasn't there, and the purchase was just more because of the fact that doctors were scared that they had to get it, but they didn't get what they actually needed. Taking this a step further, EHR companies aren't required to share data. I don't know if you're aware of that. So they have no incentive to help. They've already sold the technology, and if someone has to pay for access to patient records from other systems, that's a revenue stream for them to help with that interface. So switching EHRs or EMRs is extremely costly and time consuming, and so it leaves physicians a few options, but vendors jump up and down, oh, ours is better. And there is no perfect one out there, just so you know. But when you're looking at interoperability and why we can't seamlessly move data, part of it is because we're still in a growth there, but it's going to require some action. And some of that will come in the form of regulations issued by the Office of the National Coordinator for Health IT. And the acronym for that is ONC, or ONC. And this is, yes, it is the government, but one of the key regulations being crafted as part of the 21st Century Cures Act passed in December of 2016. This focuses on stopping data blocking, the willful policy by companies and healthcare organizations of preventing health information from being shared. I don't even know if you knew that act was out there. But healthcare providers and technology developers may have powerful economic incentives not to share electronic health information. And so I see slow progress towards the liquidity of having this actually interface. The Cures Act confronts information blocking by providing a comprehensive response to those concerns. So the information blocking provision addresses actions that can impede the flow of electronic health information. And hopefully that act, now that it's being moved forward quite a bit, because they're working on initiatives to make health records accessible, but they're trying to really improve health and delivery of care. So as they're working on, these initiatives, they're trying to make sure it's also a safely exchange of data. Remember, we have to deal with HIPAA, and that means privacy sharing for the patient information with outside non-clinical entities. That's what HIPAA is about. You can't share information with somebody who's not, I don't want to say interfacing with the patient, but who is not active within the care of that patient. But other providers, that's not part of HIPAA, and I don't think people recognize that. But here are my thoughts on this, and this is one I want you to think about after the podcast today, just about interoperability, because sometimes we have to be careful of what we wish for. So how should interoperability work to best benefit doctors? Okay, so for instance, should the information be pushed to the physician or pulled? Meaning, does the doctor have to actively search for the patient's record, or should all data be automatically delivered to all the patient's providers, no matter who they are? So there are pros and cons to both approaches, and this is what I mean when I say pushed or pulled. So pushed information may be more convenient, but might result in information overload. So the push approach, a clinician might come to work Monday and find 200 messages pushed from various entities, so discharge notices, lab reports, path reports, x-rays, consults, everything from over the weekend on a patient. And the physician could spend the entire day going through all that data just for one patient. The pull approach requires the physicians to spend time searching for the patient's information or their staff, but ensures the physician gets only the specific information they require. So the best solution may be to combine both approaches, where priority patients, such as those who are in the emergency department or the acute care setting or trauma, have their information pushed to their physician as part of an alert, while data for routine exams is pulled when needed, but all data is accessible to a degree. So this is not just a problem of getting data, but getting the right data at the right time and prioritizing it. And the industry has a long way to go before we get there because it's very subjective. Almost all of the issues affecting interoperability are offshoots of its own newness. A recent vendor I vetted, Commonwealth Health Alliance, a nonprofit trade association, they're focused on universal access to health data. They have more than 45 million patient records available through their network, and they tell me they add more than 2 million each month of these patient records. So they reconcile what they are doing to promoting interoperability to early growth stages that are very similar to what the internet was in 1997 and 1998, of course, without the sound of the dial-up phone. Remember that? Every year, health data is becoming a bigger and bigger part of life, which is very similar to internet and development. But like the early years of the internet, there remains a lot of questions about quality and consistency. There's a huge body of work and a big body of hype in this space. So today there is a concerted industry effort to get the data that is produced to be more consistent, complete, of higher quality. And in the short term, the data itself still needs to get better. So I've seen a lot of progress in the last 10 years, but I can tell the physicians are still frustrated. Progress isn't the same as satisfaction. Remember, I mentioned a long time ago in one of my podcasts, change is not good. Good change is good. So we have to have satisfying progress. It's safe to say that folks are not satisfied with the progress made to date. But think about it. The government and private sector forces have been driving interoperability to date. But I think who's going to play a significant role in the coming years is actually a third player. And for me, that's the consumer. If you look at all the entrants into health IT, they're focused more on consumers. So devices like smartwatches generate patient data. A new smartphone app allows consumers to track everything from your exercise to breathing to your medication usage. I think you will see more interoperability based on that demand because it will not just be government, but consumers will demand more interoperability. So the industry is focused on enterprise and large academic centers, and that's where you'll see the advances happen, probably more recent, or I should say sooner rather than later, looking forward. But on the other hand, smaller practices, and they may not get to see all the benefits, which is kind of unfortunate. But I recommend that you talk to your physicians, that they talk to their electronic health record vendor. Tell them that you want the ability to access or to get access to the data because of patient data, because a lot of times vendors are saying that they aren't hearing a demand from their customers. Without that demand, it won't move forward. And if your EHR vendor is not planning on adding interoperability access, meaning that you can interface with other EHR, EMR systems, it may be time to look for another one to avoid being left behind. So you need to be involved in developing the rules on the road for interoperability. Sharing data without rules or understanding, it's not going to lead to better or safer or even more affordable healthcare. So there's opportunities for physicians here to have a say in how this is all developed and to check with both vendors and health information exchange websites to learn how to get involved and offer feedback. So interoperability is happening now in the U.S. healthcare the way the internet happened for us in the 90s. Like the early internet, you can either wait and be at a disadvantage or participate now and have a say in how it improves for your practice. And realize 10 years from now, you won't even know how you live without it. So it's really time to take a look at that. So my coding questions today, so I have a couple. So let's talk about my first one here. Question came in from one of my subscribers in South Carolina. said, Terry, I got my first job in the medical field, and I've seen the word APP, or the acronym, all capitalized letters, around occasionally. When I see that word, it is an acronym, in non-medical context, I think of applications like for a phone. Is it an app? What does this mean while I'm at work? Okay. The app, or APP, is an acronym that's becoming more popular in the medical community as a replacement for what you probably have heard, NPP, non-physician practitioner. So now APP stands for Advanced Practice Provider. Okay, so it's still basically a nurse practitioner, PA, but they've grouped them now into an APP, and they actually have that listed now in the CPT book. So you want to look at APP as something that's kind of moving forward with just some new language, different ways to say things. I talk about revenue cycle management all the time, when really the back end of that is collection and appeals. And so you just have to get kind of familiar with some of the new language, new terminology, new acronyms. My ICD-10 today is from a Nebraska subscriber. She says, Terry, I have a patient who the physician documented atypical atrial flutter, which is an ICD-10 code, but I don't know which to report. Can you help out? Okay, so atypical, or I should say typical A flutter, is I-48.3. If the cardiologist had documented an atypical atrial flutter, you would have I-48.4. So if the type of flutter was unspecified, then look at I-48.92. Just so you know just the difference. So A flutter defined: when a patient has an atrial flutter, rapidly fired signals make the muscles in the atria contract quickly, which leads to a fast, steady heartbeat. So physicians should always document the atrial flutter as either typical or atypical, and also make sure the physician specified that it is A flutter instead of atrial fibrillation, because there'd be a completely different code for that. Now, my next two, I have to shout out Christina. She is an ophthalmology group billing director who gave me a really nice message on my Instagram account. And apparently I'm her new BFF. So shout out to you, Christina. And here are a couple of billing and coding questions for you. So what is the correct ICD-10 code for a patient with primary open angle glaucoma right eye, moderate stage? Your answer would be H40.1112. And then another one, so a person, this is for retina, a person with diabetes undergoes a pars plana vitrectomy, periretinal membrane peel, repositioning and suturing of the dislocated IOL, which CPT code is appropriate for claim submission. So we also have the interocular lens, for those who don't know what IOL is. So your codes would be 67041 and 66825. That's actually also on the coding exam for ophthalmology, so if you're interested in that. Our coding questions are brought to you today by Gaffey Healthcare. Better technology, better results. GaffeyHealth.com. And iMed Management. Ophthalmology billing across the U.S. iMedManagement.com. So my personal tidbit for this week, and it actually kind of goes along with the interoperability thing we were talking about. So I know a lot of you know I love sports. I love my baseball, love my football, but this is Masters Week, and I'm actually recording on a Saturday night in my office. And I was watching today, so I don't know who won. By the time you listen to this, you'll know who won the Masters. But Tiger Woods is one back with under -10 on a Saturday night. But what was really funny is that yesterday on a Friday, he was actually 7 under or 6 under, and it was funny for the day. And on my phone, it said, when I looked down, it said he was 7 under going into first place. And I was waiting to hear it because it looked like the phone was ahead of the recording. And so then when they kept saying it, they're like, oh no, it never came up. He was still 6 under. And then all of a sudden I looked down at my phone and they changed it. So that's kind of the same thing when it comes to interoperability. Even though we want to interface with everything, things as simple as a phone where they're putting data in and just, it comes up incorrect. How many times have you looked at a score on TV going, they're not winning by 40 points, and all of a sudden you look back up and it's gone? Or I just was watching the basketball playoffs have just started for the NBA, and they switched the two teams' score on accident, and you look back up and it's now fixed. So we'd have to consider that too. Remember, it's human error for some of those things to happen. But I just thought that was kind of amusing to me, just being told that something was happening, but you look down and then you basically hear it and it didn't happen that way. So always keep that in mind when you're looking at a lot of interfacing and things, because not just professionally, but it can happen to you personally too. We don't want that to happen. Also, as a reminder, everybody, if you could do me a favor, if you're listening to me on iTunes or YouTube or Stitcher Radio or any of the platforms, if you could leave a rating and possibly a review, I appreciate it. A nice review would be even better, but I would really appreciate that. So they're always asking us for reviews and updates and things like that. So thank you very much. And we're close to 50,000 listens. So everybody, I really appreciate you every week, and hopefully you're finding the information helpful. So everyone, go out and make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.